He is a consultant gastrologist, hepatologist, intervention endoscopic at Apollo Mains Road, Greens Apollo. He is mainly interested in interventional endoscopy and liver transplantation. His achievements are he is a faculty in national AIDS conferences like INSA, ISG, TNSG, ACG, API and IMA. And moreover, he has published a lot of publications in put together all over Indian level and Europe level also. With this, Dr. Arun will take the first presentations and followed by the session 2 will be taken. Session 2 is the evidence-based role of azithromycin in URTI management. It will be taken by Professor Dr. M.N.
Who is supposed to chair the session first, but since I have an important appointment, just requested him to give me an opportunity to talk on this slide first. Today we are here to discuss on various topics, but predominantly one is happening. The first topic is slightly different from the major entirety what's happening in the pediatric population and the population. The main thing right now is the common clinical scenario that we are coming across in routine practices. Without this, we will not be living a routine practice. If you are being a physician or a family physician or gastroenterologist or surgeon, we'll be coming across this kind of aseptic disorders. It's a huge, broad-based entity. Among them, there are multiple other subdivisions that be coexisting. It might be your GERD, which means a reflexive, gastroesophageal reflux. In case if the patient is having a sense of reflexive from your stomach into your esophagus, nothing into your food pipe, that might be evidence of gastroesophageal reflux. And if it tends to be heartburn, regurgitation, all the problems in case if it is going to get happen, then the problem of GERD is going to get supervised. So how are you going to approach a patient with GERD? How are you going to investigate briefly for next 15 to 20 minutes what you are going to address here? So that's what the major indication. Apart from that, what else is there? So peptic ulcer. Among peptic ulcer, the next common indication will be your gastric ulcer or duodenal ulcer. So how are you going to approach? Are you going to diagnose or are you going to check? And apart from that, functional dyspepsia. It's a huge common entirety characterized by two major entities. One will be epigastric pain and postprandial dysfunction. See, briefly about how you're going to approach on all these scenarios is very, very important. The most important thing is there might be overlap. In field of gastroenterology, always each and every symptoms will be overlapped. It might be GERD, coexisting peptic ulcer, or you might see among GERD, the first characteristic phenomenon will be whether it is erosive reflex or non-erosive reflex. What do you mean by non-erosive reflex? There is a classification what's called as Montreal's classification. In that classification, it has been broadly categorized based upon your esophageal symptoms and non-esophageal symptoms. Any problem which is happening in the upper GI tract, there will be having a common reflex or symptom. So what is going to happen? The esophagus and trachea will be having a common innervation, though at the time, most of the patient will be having not only a reflex, they might be having other evidences like your laryngitis, your pharyngitis, probably the next speaker will be taking on. So all this coexisting otitis meeting up, this is all the bronchial asthma, will be having a coexisting trigger. So if you are not going to address those manifestations properly, your GERD will not get respond. So even with the best of treatment, whether you are going to subside with GERD, no, 30 to 40% will still land with evidence of refractory presentation. So to whom you are going to tackle, how are you going to recognize, to whom you are going to investigate, when you are going to start the patient on treatment. If you are going to start the patient on treatment, how are you going to escalate and de-escalate the patient on treatment? This is what is very important when you are going to look into the picture of GERD. The first and foremost important thing is, first we need to identify the precipitating factors, identify the condition. For example, in GERD, two major entities, non-erosive reflex and erosive reflex. Among this, non-erosive will be in 60 to 80% of the population will be very characteristic. You need to subject the patient for endoscopic survey. When you are going to do an endoscopy, you need to identify four grading system, what is called as Los Angeles. I'm not looking at the slides much, but just remember certain important pointers if I'm going to find. One is Los Angeles classification. What is the Los Angeles? It's stage A, B, C, D. In that, if the mucosal break, if it tends to be less than 5 millimeter, that means the stage A. If it is more than that, the stage B in esophagus. If it is almost around 75% of the circumference, which means stage C. If it is going to be more than 75, which means stage D. Why it is important to categorize? Because based upon that, you need to decide the management. If the patient is having severe esophagitis, erosive esophagitis, which means there is a high risk for this kind of patient to predispose to various changes like your Barrett's, adenocarcinomatous changes, which is one of the worsening malignant changes which is happening in the esophageal tract. So all this picture we need to understand. What do you mean by Barrett's? It's nothing but your metaplastic changes in which your columnar is squamous epithelium of your esophagus being converted by metaplastic with your columnar epithelium. So in which what's going to happen, this kind of changes will be a high risk for the patient to progress for adenocarcinoma of your foot pipe. So this is what we need to address. So erosive esophagitis is very serious pointers we need to see. And apart from the huge list of differential diagnosis, it might be peptic ulcer based, it might be NSAID abuse. Recently also I came across a patient who had evidence of naproxen, diclo, followed by the ad for evidence of rheumatological picture. They have been treated with multiple doses of naproxen, and the young boy, almost around 20 to 25, they have been suspected some fever patterns, and he have been given naproxen for almost around a month of duration, and he had evidence of dysphagia. It's a strong alarming point. So I just looked into the endoscopy. The esophagus is completely burdened. The mucosa has almost burdened, which means severe esophagitis. So I requested him to stop all the molecules, and then I initiated high dose regimen of PPI or PCAS, whatever the best of things is available, and that patient responded dramatically well. And almost it took almost 2 to 3 months of therapy for him to get the mucosa healed up. Why I am addressing this thing is because whenever you are going to tackle with such kind of presentation, it's very important to recognize whether the patient is responding or not. So Montreal's classification is very important. Based upon that, you need to categorize a non-erosive and erosive. Among this, in GERD, the basic clinical manifestation is heartburn and regurgitation. Apart from that, once the patient is going to diagnose with GERD, what is the investigations you are going to do? Is it necessary to investigate the patient? Yes. Because if the patient is having refractory presentation, you need to do a proper investigation, what's called as a deep Michel scoring system, which means impedance metry. Whenever you are going to develop a reflex, there are 4 major mechanisms. You should remember that. One is based upon your hiatal hernia, which means the sphincter, if it is going to be more loose. The other mechanism is a TLEACR, so which means a transient lower esophageal sphincter relaxation dysfunction. So if the pressure is not going to be maintained at a rate of around 10 millimeters of mercury, which means the TLACR sphincter is going to get augmented. That means there is an area for the patient to get more of reflex episode, which will be predisposing for further impact. Your diaphragmatic pinch back mechanisms, so many mechanisms are there, and poor esophageal mucus defense, salivary clearance. These are all the pathophysiological outlining on even the duodenal mucosal defense. So we should remember that starting from your esophagus, your stomach, as well as your duodenum, proximal small bowel, there are major mechanisms which is going to get involved in the pathophysiological concept of GERD. So once a reflexate, if it is going to get act on, which means the patient will be landing up with evidence of GERD. So how are you going to address? There might be acidic reflexes or non-acidic reflexes. It might be alkaline reflex. If the pH, if it is going to be more than 4, 5, 6, and 7, which means the alkaline reflex is going to get checked on. Acidic reflex. So all these things, we need to look for a scoring system, what is called as de-Michel scoring. Why it's so important? Because that will identify your reflex episodes. When the patient is standing, when the patient is sitting, when the patient is prone, supine, various positions, you need to identify the reflexate, what is going to happen based upon your impedance metric. That's called 24-hour impedance pH metric. So based upon that, you need to diagnose your reflexate. What you're going to do, you need to measure with a probe in which you're going to keep at a rate of just above the lower esophageal sphincter to the endoscope, and then you can be able to identify the reflexate which is going to get ambulatory pH monitoring, which is important. There are so many new innovations are there for reflexate identification, like your Bravo capsule and all those things, but that's not the area of discussion right now. Briefly, what I would like to say, there are so many pointers. We need to calculate reflex index is active or not. If it is going to be more than 14, which means the patient reflexate is significant, you need to treat the patient adequately. So this is all we are going to diagnose. So in gastroenterology, remember very symptom, always the problems will be overlapping, most of the molecules are there. So how are you going to address? Overlapping because of your GERD, peptic ulcer, functional dyspepsia, irritable bowel, psychosocial symptoms, all these things will overlap. So recognizing the patient is very important, tackling the patient is very important. Even if the best of gastroenterologists, whatever the best of molecules you are going to choose, starting from your H2 blocker, your alginates, or your PPIs, double dose regimen, dual dose regimen, high dose regimens, or apart from that when you're going to use your PCAS, prokinetics. Now algin is another preparation. Even with the best of treatment, most of the patients may not respond. More than 30 to 40% of the patients will still have evidence of refractory presentation, because it might be a combination of multiple triggers. It might be a coexisting overlapping of irritable bowel, it might be a coexisting overlapping of functional dyspepsia. All these entities we need to address when you are going to tackle a presentation in GI. But before addressing, we should always remember alarming pointers. It's like a calculation which is happening in mathematics, as you are well aware. The alarming pointers in GI is very simple. If you are identifying any evidence of unexpected weight loss, if it is going to be more than 10% of weight loss, for example, if the patient is 80 kg within a span of 1 to 2 months, if the patient is dropping around more than 8 kg, which means the patient is alarmed. Number 2, unexplained source of bleed. We don't know where the bleeding is coming from. So there might be evidence of drop in hemoglobin, anemia. Very characteristic, we should not forget, it's very alarming pointer. It might be upper GI or lower GI, or it might be in small bowel or proximal or distal. All this picture we need to be very cautious. It might be overt bleed or rectal bleed. These are all the separate entities. And when you are going to identify a patient with dysphagia, it's always alarming. Dysphagia, it might be mechanical, obstructive, various etiological, and motility based, but you need to alarm the patient if he is having evidence of dysphagia considering the age of presentation, whatever. And once a patient, if you are going to identify any mass, if you are palpating the gastrointestinal tract, if you are going to identify any mass over the tummy, which means it's alarming, you need to be very cautious. You need to look for evidence of subacute obstruction or obstructive picture, or in the mass, or whatever the things we need to see, we are landing with alarming event. So this is all the basic GI alarming pointers to look for evidence of in your GI tract. What is predominantly focused when you want to address this kind of picture? If these alarming pointers are not there, predominant or reflexive, which means the gastric reflex is going to get shaped off, and there are a list of investigations to look for the diagnosis and management, starting from, as I already been discussed, H2 blockers. H2 blocker, fantastic molecule, but the problem is will yield only one grade A, grade B esophagitis. Once a patient is going to land with evidence of grade C, D, no major role for H2 blockers. So what is the next line of molecule? So your ranitidine, your famotidine, your recently lafitudine, so many molecules are there at rate of 10 millions we can give, but still no major role to consider in the background of reflex esophagitis of almost stage C and D, no major role. So the best line of molecules starting from 1980 onward that we're looking for your PPI, starting from your omeprazole, your pantoprazole, all these molecules right from your ribiprazole, esomeprazole, all these things. But what is the best line of PPI we're going to choose? High dose regimen, double dose regimen, dual dose, enantiomeric preparation. For example, dexlansoprazole with enantiomer. They'll be releasing at a pH of almost around first initial phase of life, around 1 to 2 hours they'll be releasing, followed by 10 to 12 hours of dual release preparations are there. So in these things are all you can able to maintain a sustained acidity. The problem is, it is going to, the problem with PPI. So PPI, you list of adverse events is there, but how do you going to recognize those kind of scenarios in India is still a challenging task. Apart from that, when you are going to start a patient with PPI, first thing is, what's the best line of PPI you are going to choose? And what are the various coexisting presentations for the patient who is having evidence of PPI? For example, if the patient is long-standing cardiovascular events. For example, if the patient is having any major acute coronary event. For example, if the patient is having evidence of metabolic associated steatotic liver dysfunction. So if the patient has obesity and obstructive sleep apnea, so many other coexisting presentations. So you need to see the entire comorbid picture before you are going to use. Just like that, if any patient comes with reflexive syndrome, just like that, prescribe the patient with PPI, because that will land up with further alarming picture. Whenever you are going to get a cardiac presentation, you need to choose the best line of molecule like rabiprazole, because rabiprazole, the interaction with your CYP, that's very common. The CYP2C19 pathway will be a characteristic interaction with your PPI. So at that point of juncture, once the patient is going to use your clopidogrel and other molecules, there is high possibility for the patient to have worsening of presentation. So you need to be very cautious. The drug interaction levels will be going down, and the patient cardiovascular major acute coronary events may get worsened. So if to those kind of patients in the background of cardiovascular, best line of molecule, in order to address your CYP, you need to use your rabiprazole. And for example, when you are going to choose your prokinetics, the best line of prokinetic will be etopride. And why Because the problem with PPIs, it will take acid inhibition. Irreversibly, it's going to inhibit your acid pump. It is going to locate in parietal cells of your stomach by a binding what's called as covalent binding. So what's the mechanism? So it will be taking almost around 3 to 5 days for the pump action to get active. That is why whenever you're going to take a PPI, most of the patient will not respond dramatically. It will take at least 48 hours for the PPIs to get active. That's the problem. So in order to solve that, the new molecules like a PCABs, like a vonoprazole, now apart from the other molecules like a fexaprozole and chicoprazole are being taken over. The three major prazos are being there, and recently in APA conference we gave a guidelines for that. So the vonoprazole is very meat independent pathway, non-covalently binding and short action, rapid action. The half-life will be more potent, and the acid inhibitory potential almost around 100 to 250 times more potent when compared to your PPI. And the rate of adverse event will be very, very less. So you can use your vonoprazole when compared to your drugs we can consider. What are the various indications you can use your PCABs? You can use in GERD, erosive esophagitis, definitely NSAIDs induced esophagitis. Apart from that, your H. pylori eradication, your peptic ulcer disorders, and your functional dyspepsia you can try, but there is no major role. But your functional dyspepsia, the pathway will be entirely different. So why I would like to say PCABs still you can consider because it's mean independent and you can consider safely the adverse events when compared to other molecules. And moreover, with PCABs, for example, your vonoprazole, fexaprozole, or chegoprazole, whatever you are going to use, the rate of adverse event by your CYP pathway will be very less when compared to your PPI, because it will be predominantly acting through CYP3A4 rather than 2C19. So that's one characteristic indicator we need to differentiate. So whenever you're going to use this kind of molecules, use list of molecules, vonoprazole, the rapid onset, the labs and all those things, but what we supposed to say, we need to look for the pharmacokinetics, clinical perspectives and all those things whenever we're going to use a molecule. And your alginates for short acting, it will be having a buoyant effect. So what's going to happen in the hat trapping? They will be having a mucosal protection like your sucralfate, it will be having a hat trapping effect will be there, the buoyancy effect will be there when you're going to use your alginate preparations, because the raft which is going to mainly derive from the plant extract, it is going to form a raft pocket which is happening. So alginate preparation for short duration we can consider. Acute presentation, severe reflux, knock-in symptoms, you can give alginate. But the problem is it will be acting for short duration, and apart from that, it will not control the healing phase. The healing mucosa will not be non-erosive reflux, okay to some extent, but erosive pathology, ideal molecule will be, we need to choose for either a PPI or PCAB. Those two molecules will be significant. H2 blocker you can consider. The best line of indicator for H2 blocker is your NAB. What is the NAB? Your nocturnal acid breakthrough, which means once a patient will be taking PPI in the morning, but night time they will be on severe reflux, which will be making the patient to go for nocturnal lavectomy, and the patient pH will be dropping more than 4. At the point of juncture, the patient will have worsening of presentation. In order to control that, we will be giving the patient with morning 1 dose of PPI, and night time they will be hitting the patient with high dose of ranitidine, almost around 300 milligrams a dose, to prevent this effect. The nocturnal acid breakthrough phenomenon, you can combine your PPI with H2 blocker. H2 blocker will be having significant potential role to control your NABs. But problem with PPI, NABs, the control rate will be very, very less, almost only 20 to 30%. But one good thing with PCABs, the nocturnal acid breakthrough phenomenon will be very, very less, almost around 70 to 80% of protection will be very good with your PCAB. That is why the rate of PCAB. The problem is, whenever you are going to look for the molecules like PCABs, PPIs, huge list of adverse events. What are the common adverse events? One is metabolic disturbances, for example, electrolyte, your hyponatremia, hypomagnesemia, and hypokalemic changes. Apart from that, your bony changes, your rickets problem, osteomalacia, osteoporosis, and apart from that, huge list of, for example, the problem in intensive care. If you are going to have a patient in intensive care, there might be evidence of septic focus. There might be evidence of worsening of septicemia like CAP, community acquired pneumonia, or if the patient is having clostridial deficit infections, or if the patient is having any GA infections. At that point of junction, you need to be very cautious to use your PPI, because the gut microbiome that has been taken over as a separate area to discuss now in the field of gastroenterology. That microbiome, if it is going to get disrupted, that means the patient will have a worsening of presentation. So whenever you are going to use a patient with PPIs, you need to be cautious with the intensive care, worsening of septic focus, SARS, septic shock, At that point of juncture, in the background of metabolic liver disease, in the background of cirrhosis and other complications, the PPIs are no major role to be considered. Rather than we can go with H2 blockers in these kind of scenarios when we want to address, because that might worsen your infection at that point. So you list, and when you see, we have been coming across, for example, in primary health center, for years they have been using PPIs. For every year, almost 3 years, 5 years, they've been continuously giving omeprazole. We have been coming across in various primary health centers in throughout the remote population of Tamil Nadu. We have been coming across with this kind of scenario. So what is going to happen? There might be evidence of funding gland hyperplasia. So you are going to do endoscopy. You will be seeing various multiple polyps in the GI tract. So that will be one of the characteristic problem. Why such things important? But that funding gland polyposis will be having a risk of malignant changeover as the patient. But even though the rate of progression will be less, but still we are having papers to document that the risk of malignant changeover, even with the funding gland polyposis, is one of the adverse events with your PPIs to be considered. So, okay, these are all adverse events with PPI. What else with PCAPs? Still, in PCAPs too, there might be having evidence of adverse events with similar potential. But the PCAP we have been using only for the past 2 years. So, we need more and more data, we need more and more papers to support all this beneficial role. As I already discussed, the dose escalation, reduction, escalating molecules and all those things, always start the patient with basic molecules like PPI and look for double dose PPI, hit the patient with high dose PPI, and apart from that, if the patient not responding, have the patient with alginate other preparation and slowly escalate. So always the duration of therapy will be 8 weeks to 12 weeks. For example, in gastric ulcer, so gastric ulcer and duodenal ulcer, how are you going to differentiate? The one which is going to worsen with your food intake is your gastric. Improve with your food intake with your duodenal ulcer. You list a classification out of area to discuss, but once the patient is going to land with evidence of this kind of ulcerative picture, you can give a duration of treatment of almost 6 weeks to 8 weeks. In gastric ulcers, the duration almost around 8 weeks, but the duodenal ulcer we can give up to 6 weeks of therapy. But whatever the areas, the maximum role of regimen will be 8 to 12 weeks of therapy with your PPI or high dose, what you are going to consider, or PCAP at a rate, what you are going to consider. And this is what the escalation and de-escalation has already been discussed. You list hypergastremic effects and all those things. So that is why if you are going to use PPI, persistent low-S hypergastrinemia, that will be predisposing the patient for funding gland polypotic changes. So you need to be very cautious when you are going to address. And as I already been discussed, intermittent, rapid relief, cost-effective mechanism and all those, these are the basic things. Remember, severe reflux, mild, non-erosive, this is what the guidelines. So start with PPI or PCAP, see through that if the patient is responding for a duration of 4 to 8 weeks of therapy. If the patient is responding, well and good, not responding, look for the differential pictures. For example, refractory, it might be functional or bad, it might be reflex hypersensitivity. For that, you need to look for evidence of what is that Mr. Demis scoring and your ambulatory pH battery. And all these things pointers is important. Manometry, is there any role? Means usually no major role, unless and otherwise you are going to suspect any evidence of motility disorders. Because, for example, if achalasia, the motility disorder, that might be having evidence to look for a picture of your manometry, to look for evidence of various TLSA changes and all those things. So pregnancy, always PCAPs, still we need more and more papers to support, so better to avoid PCAPs in pregnancy as of now. But apart from that, PPI is no major worsening of events, you can very safely give in pregnancy. Clinical implications and all those things have been discussed. And already been discussed the endoscopic benefits. Always we can able to identify the Barrett's, peptic strictures, malignant changeovers, and very important. Next to that, your peptic ulcer. So once you are going to diagnose with peptic ulcer, H. pylori. H. pylori, eradication of H. pylori is very important. What is the various regimens? One is your clarithromycin, metronidazole, bismuth, along with your PPIs. Nowadays, dual therapy, triple therapy, quadruple therapy, dual therapy, levofloxacin-based therapy, rifampicin-based therapy. So many therapies are there. But we should remember, triple therapy, very characteristic. Quadruple therapy along with your bismuth. Bismuth you can consider a rate of 240 milligrams BD, in which if you are going to give bismuth along with your PPI, clarithromycin and metronidazole, so it will be very safer. But in case if you want to give a different regimen, for example, dual therapy like your amoxicillin as well as your vonoprazan can be considered nowadays. High dose amoxicillin, almost around 2000 milligrams BD, you can consider for your amoxicillin. But the problem is when you are going to treat the patient with such high dose therapy, that might be having worsening of irritable bowel, worsening of changes. So that is the problem when you're going to address. Always when you're going to use amoxicillin, these kind of things we need to be very cautious, because to whom we are going to use, that's what I've been discussed, when are you going to use, what is the major potential events, because all the patients will not have evidence, even though if the patient is having huge list of indicators to look for evidence of H. pylori. So H. pylori, very characteristic pathogen to look for worsening of adenocarcinomatous predisposing factor. So you need to treat the patient for H. pylori to prevent the patient for GA malignancy, but still, what is the best line of therapy is your quadruple therapy with your PPI, amox and clarithromycin. But the problem with clarithromycin in Indian scenario, there might be a huge list of resistance to clarithromycin. So we need to be look for the data, how to going to choose whether clarithromycin resistance testing and all those points is indicated. And once the patient is going to start on H. pylori, how are you going to monitor the patient? And urea, blood test, serology, invasive markers, and frequently we are coming across with practitioners who are doing frequent urine sampling for H. pylori. The first sample tends to be positive, they will be giving management, and immediately within a span of a week they will be repeating the sample. That also tends to be positive. Whether it's indicated to start the treatment again? No, because always we need to wait for a duration of almost around 2 months in order to look for the potential benefits that happen. So it doesn't mean that even one pointer tends to be positive, frequently you need to treat the patient for H. pylori. No, you need to wait, watch, assess, monitor. And H. pylori, this is what is very important. A huge list of indicators to diagnose, and the treatment guidelines, multiple regimens, triple and quadruple, very important. And your functional dyspepsia, and has already been discussed that peptic ulcer, this is what the major guidelines already being addressed. And apart from that, the diagnostic testing useless, vonaprazone can be tried for the H. pylori, vonaprazone, clarithromycin, PCABs and all those things. But once, so refractory ulcer. And what is a refractory ulcer? Even if you are going to treat the patient with H. pylori regimen, sometimes the patient deduces ulcer because of the lack of visibility, the mucosal, because of the blood adherence factors and all those things, that might be having refractory changes. At that point, you need to hit the patient with high dose. Nowadays, intensive care regimen protocol, you should not forget that. Start the patient with 80 milligrams. If the patient has a huge list of diurnal ulcer, the patient will be a risk of bleed. If the patient has anterior ulcer or posterior ulcer in the diurnal, there might be a risk of bleed and perforation. So you need to be very cautious when you are going to address, and hit the patient with high dose PPI like 80 milligrams bolus followed by 8 milligrams per hour continuous infusion followed for a duration of 3 to 5 days, and then slowly de-escalate the patient with oral therapy and maintain the patient for almost 8 to 12 weeks to address this kind of presentation. So refractory, need to be very cautious, and you list a differential diagnosis. For example, your Zollinger-Ellison, your Barrett's, adenosis, and eosinophilic esophagitis, or refractory GERD, proper non-adherent psychosocial factors, and these are all the organic and non-organic factors we need to see once the patient is going to have refractory factors of your GERD and other presentation. And so as I already discussed, the intensive care guidelines, clinical implications. So H. pylori indication is your and functional dyspepsia. So what is this functional dyspepsia? It's a different entity. One is postprandial dyspepsia. You'll be having frequent bloating, dyspeptic symptoms, belching and other things, epigastric pain and postprandial distress because of the visceral hypersensitivity which is going to get happen, and altered motility which is going to get happen in your gut. So once the patient is having frequent bothersome symptoms like your postprandial distress, bloat and your reflux and other episodes, which means the patient is landing over the evidence of functional dyspepsia. To functional dyspepsia, the best kind of molecule to consider is eclotiamide, which is predominantly be taking on with the pathway of 5-HTP agonist. But when you're going to look for other pictures like your PPIs and PCAPs to be considered as armamentarium to add on with your prokinetics to consider. And very importantly, gastroparesis will be having similar presentation. Gastroparesis is still a challenging task when you're going to address. So this is what the basic area. And functional dyspepsia, this is what the basic workup. Most of the pointers, functional dyspepsia, the problem is psychosocial component. You will be treating the patient, but the patient will not respond. You will be frequently changing the doctor. So what is the problem? The psychosocial component has to be addressed strongly. Whenever you are going to land up with this kind of postprandial distress, epigastric pain, frequent bothersome manifestation. So at that point, your TCAs or SSRIs, you need to consider for this kind of patient whenever you are going to address with such kind of functional dyspeptic patient, because doesn't mean that you are going to use a patient with molecules, you are going to get response. So you need to address all this picture properly in order to tackle this kind of GI symptoms effectively. And before concluding, what I would like to point out is recognizing the patient as a whole, look for the proper etiology workup, and what is the well-deserved investigation we need to do. We need to look for that. Whether the patient deserves endoscopic surveillance, okay, fine. Whether the patient deserves your manometric surveillance, or whether the patient deserves your D-misses scoring. And prior to that, now we should remember very importantly before concluding, for example, if the patient is not responding, so many innovations happen in the field of gastro to look for endoscopic intervention. That's called your endoscopic fundoplication. Other things, strata procedures, your GERD, stricture, and magnetic-based procedures. So many other things are there. But GERD, to tackle refractory GERD, once patient is there, not responding to any molecules, the D-misses scoring is worsening, then you can consider that kind of patients for endoscopic intervention based upon your strata. So many radiofrequency ablation procedures are there. Nowadays, the field of gastro has been innovative. So I look for, rather than going for surgical intervention like your fundoplication of Nissens or toupee, rather than considering only that, now it's outdated. More of endoscopic interventions have been taken over, and so it's better to consider for endoscopic intervention if the patient is having refractory evidence of GERD and other presentation. So clinically recognize, look for the complications, tackle the patient effectively, choose the best molecule, address the comorbidity is very important in order to tackle this GERD and multiple other presentation of functional dyspepsia or peptic ulcer effectively. With this, I'm happy to rest. Thanking you all for patience. If there is any questions, I'm happy to take on. PCAS. For example, your PCAP with your clarithromycin and your amoxicillin you can consider. Or only high dose amoxicillin with your PPIs you can consider. The problem is to whom you are going to use is very important. Nowadays, the rate of vonoprazan administration even for the acute presentation of GA grade, with the patient with acute GA grade, there is a procedure what is called as endoscopic 78% dissection. In that kind of background, there is a high risk for the patient to go for GA bleed. Even acute GA bleed, rather than going for infusions, we can give PCAP, which is a rapid action. Most of the time, we can able to consider as an alternative regimen in case if you are not having any source to with the therapy of IV line access. So PCAP still you can consider, but the best kind of treatment always for H. pylori eradication will be your coordinated therapy. The rate of response almost around 90 to 95%, and triple therapy with your vonoprazan is almost around 90 to 90%, and triple therapy with your PPI clarithromycin will be 80 to 90%. But the rate of resistance will be the higher side. You need to look for all this picture when you are going to tackle that type of presentation.
So this applies to mild, moderate, or severe
It's not about H. pylori mild, moderate, and severe. There is no separate guidance to see whether the patient has H. pylori mild, moderate, and severe. It is only to see whether the patient is having H. pylori positive. But the problem with H. pylori is how is going to diagnose? Urea blood test, is it available everywhere? No, difficult task. And apart from the invasive procedure, you need to do an endoscopy, take a biopsy from the anthropylori region, various regions, and then you need to look for the serial diagnostic marker. Or serologically, you need to see for diagnosis. Or urine markers are there to look for H. pylori. But these are all non-sensitive. The best invasive investigation is show H. pylori, go for the biopsy, give the patient directly, and then get the conclusion. But the problem is H. pylori could be a normal commensal too. It might be a normal commensal even when you are going to see through that. If your patient will be treated with H. pylori regimen, I think you are going to do a biopsy, the patient will have H. pylori positivity. So is it indicated for the patient to be treated? No. So that's what is important. Addressing the patient as a whole is important when you are going to address this kind of presentation.
The role of probiotics in H. pylori.
Definitely, rhamnosus, lactobacillus rhamnosus, GG, and an add-on, along with your rotary good molecule should be considered as an add-on potential, because whenever you are going to use any GA molecule, usually the chances of worsening of irritable bowel, because GERD, the patient will come to the gastroenterologist as last entity. The patient will see multiple physicians, all those things, followed by the last year the patient will come for endoscopic and other things. The role of probiotic is still towards star because irritable bowel will be a coexisting overlap presentation. So you need to consider probiotic, but not only for that, even with H. pylori eradication, the role of probiotic will be an institutional potential because it benefits other things. The rhamnosus, the rotary, and other things and all we can GG and all we will consider when you are going to use a rate of almost 4 to 12 weeks of therapy, along with the probiotic support in the background of eradication, you can still consider. But isolated probiotic, no danger, no role.
Good morning, sir. While regarding clarithromycin, why does it cause severe stress to the patient? They are not able to tolerate clarithromycin. What's the reason?
The problem with clarithromycin will be having, even though the mucosal protective effect with your clarithromycin alone will not be very strongly established. And the problem next to that, the risk of Clostridium difficile infection, for example, your clarithromycin and other molecules we are going to use, even though when compared to your tetracycline, your infomycin, clindamycin, other things, even though with that, the risk of Clostridium difficile and other infection, there are some papers to look for worsening of changes. Isolated clarithromycin alone, the problem is it might be having a coexisting worsening factors of your reflex and other things of creating the response rate of GERD. Creating the worsening factors of GERD. So while clarithromycin still holds the acid inhibition, the mucosal protection is not been well established. The problem is not, if you are going to use isolated clarithromycin, that's why always they will be combining with the PPI. So they will be having the hypogastremic effect, it will be having augmented with strong protection, and then we will be going to hit the patient with that. So the triple therapy will be more recommended rather than giving clarithromycin alone. That is why it has always been combined with this kind of presentation to have a beneficial role in GI symptoms.